Today we're going to talk about the athlete's shoulder and evaluation of the athlete's shoulder. Examination of the shoulder is important because it's difficult, and it's difficult because all the anatomical possible abnormalities are very close in region in the shoulder. So the main things we're looking at are rotator cuff pain and associated rotator cuff problems, problems of the AC joint, and instability of the shoulder. The shoulder examination starts with a generalized examination of range of motion, inspection, and palpation of the shoulder and the structures of the shoulder. When examining the shoulder for problems, you definitely want to compare side to side. And classically, the exam is done simultaneously side to side. The first thing I always start with is a range of motion test of the shoulder. And there are four ranges of motion of the shoulder. The first is external rotation. So you just want to keep the patient's elbow at their side. This is considered 0 degrees or neutral, and we take it like a clock out into external rotation. And so if he came out 90 degrees, that would be parallel with his body. The next is abduction. So we hold on to the shoulder blade, and you just want to bring straight abduction and straight abduction. The next is forward elevation, straight elevation up, and straight elevation up. The next is internal rotation, and usually we measure this by how many vertebral body heights the patient can get up, comparing one side to the other. The bottom of the scapula is usually T7, and then L1 is about the middle of the lordosis here. The other inspection that we want to look at are the anatomic structures of the shoulder. We want to look at the clavicle, and where the clavicle ends is the AC joint. What comes to make the AC joint is the acromion. Acromioclavicular joint is AC joint. We want to look at the contour of the deltoid, which is 3 portions: the anterior deltoid, lateral deltoid, and posterior deltoid. We want to look for any swelling. We also want to look for any atrophy. Next, we perform an active range of motion test, asking the patient to perform shoulder flexion. So go ahead and lift your arms up over your head all the way up and bring those back down. And do that again. And we want to look and watch the shoulder blades and make sure that they work evenly together and there's no winging. Winging is a sign of a long thoracic nerve injury. Next, we want to do straight abduction. And again, watch the scapula and watch the glenohumeral joints. And we compare side to side and make sure that there is no winging and that they work in a symmetric fashion. After inspection, we go on to palpation. And I always palpate side to side. Start at the sternoclavicular joints, see if there's any pain comparing side to side. Go on to the AC joints or acromioclavicular joints. You can feel the acromion slope here, and if you push just below the acromion, that's your subacromial space, and that's where your rotator cuff sits. So if I come over here and I feel bone, I drop right below bone, and right there I'm pushing on his, and if they have rotator cuff pain, they're usually sore in that area. If you bring the elbow next to the body and rotate the arm into a little bit of external rotation, you're bringing the biceps out in front, and you can palpate along the biceps, and they can have bicipital pain. The next area of palpation is going to be just medial to the biceps tendon, and you kind of feel the roll of the ball of the shoulder and drop in where it's soft, and that's the glenohumeral joint. And you can push right into the glenohumeral joint and push right on the joint itself. Next, we're going to do some strength testing, mainly testing the rotator cuff. So Keeping the elbows in at the side, we ask the athlete to push their hands out into external rotation. Push. That is testing specifically the infraspinatus rotator cuff tendon. Next, we ask them to push in, and that is specifically testing their subscapularis rotator cuff tendon. We next bring the arms into straight abduction and forward elevation, and we're going to be testing the supraspinatus tendon, which is the top of the four rotator cuffs. Now we can do that test thumbs up or thumbs down. Most people perform it thumbs down, and we just have them push towards the ceiling as we resist. There's a special test for the subscapularis which isolates that muscle, and it's called the lift-off test. And what we do is have the athlete put their hand like they're putting it in their back pocket. Keep the elbow in neutral to the body and ask them to lift their hand against resistance off their back. So push against my hand. Perfect. An alternative to the lift-off, if the patient has limited range of motion and can't get their hand all the way back, is hold their elbow in neutral and ask them to press their hand into their stomach. And that will also isolate the subscapularis without forcing them into a painful position. Examination of a suspected AC joint is mainly inspection, visualizing that the AC joint is elevated, palpation, and that there will be pain directly on the AC joint. And then sometimes you can elicit evidence of AC joint instability by direct axial pulling of the humeral head. Most of these injuries occur by a direct force onto the acromion without the clavicle driving that acromion down. Examination of a patient with suspected shoulder dislocation or subluxation is a rather scary test for the patient themselves. And 90% of glenohumeral joint dislocations are an anterior dislocation. One of the main tests for this problem is bringing the arm into abduction, some external rotation, and then watching the patient's face and seeing if that scares them or makes them nervous. It's called an apprehension test, in that the patient is very apprehensive that you are going to dislocate their shoulder. Next examination for a patient with suspected shoulder instability is called a shuck test, or just simply moving the humerus between your fingers. Your front finger is on the humeral head in front, and then your thumb in back, and you simply want to slide the humerus back and forth and see how far it will slide on the glenoid. Next test for multidirectional instability or generalized instability is called a sulcus test. And what we do is we apply an axial load to the humerus and look as it pulls away from the acromion. And these tests are graded. 1 is where you can pull it just enough to see an indentation, as we do here. 2 is pulling it 50%, and 3 is a complete inferior dislocation of the shoulder.